Hi everyone.
Good evening and welcome everyone to the 2019 Pertussis Webinar. My name's Susie. I represent the Immunisation Coalition here in Melbourne. And tonight, speaking about the Pertussis updates, we have Angela Newbound. She is the Immunisation Coordinator at the Primary Health Network over there in Adelaide. Welcome.
Thank you very much, Susie, and welcome to everybody that is on the webinar tonight. We are going to be talking about pertussis. So whooping cough, a bit of a problem. We definitely know that. It's a bit of a problem disease, and we've, got a little bit of a problem with vaccine coverage. So we're going to be going through what is pertussis, how do we manage it, what do we vaccinate, who's eligible for vaccination, etc. So let's get started. So just a bit of background information really about pertussis disease. We certainly know this is a very, very old disease, first described back in the 16th century, but the organism wasn't really isolated until 1906. Really damaging disease in the communities prior to the vaccine era. So it was a major cause of childhood mortality. And, quite often if you walk around old cemeteries, you'll actually find lots and lots and lots of children's graves, and quite likely it was either going to be pertussis or diphtheria that would have killed those little children. But these pertussis antigens tend to allow the organism really to evade our host defences. So the bacteria enter, they attach themselves to the cilia of our respiratory epithelial cells, and then they produce this horrible toxin that will paralyse the cilia. Now, once that happens, of course, we get inflammation of the respiratory tract, and therefore it makes it really very difficult for people to clear all of that mucus that's there. And I'm really sorry if anyone's trying to eat their dinner while we talk about all of this, but it does produce this revolting mucopurulent sapinous exudate. How's that for some words at this time of the night? In the respiratory tract, and this really compromises particularly small airways. So little tiny babies really struggle with this disease for that reason. So we know that these pertussis toxins, really have emerged as a key virulence factor for its ability to really promote that bacterial colonisation. So it's a really awful disease. It's highly contagious, spreading across, 70 to 100% of susceptible household contacts, which is pretty amazing. Maybe 50 to 80% in regards to susceptible school contacts. This disease spreads so easily, and yet it's just such a difficult disease really to diagnose, and because it's just that runny nose, that fever, that mild cough really that presents itself, and most parents realistically would just think the child's got a common cold and therefore would send the child off to kindergarten or childcare or school, and of course that child would then be spreading this disease to really vulnerable people. So we've got this runny nose. We know that there is a cough usually that develops. It's a hard disease really to diagnose, particularly in these early stages. These cold-like symptoms, like I said, are really just could be any viral illness, really. Might be a mild fever or a cough. Children under the age of 6 months, though, they present a little bit differently. They don't really develop that paroxysmal cough that is so characteristic of whooping cough, or they don't tend to develop that characteristic inspiratory whooping sound when they do cough. So little tiny babies under 6 months of age with whooping cough are more likely going to be presenting with apnea, with cyanosis, leading on to bradycardias. So just be really mindful that when little babies are presenting and they're really flat and mum is saying to them that she just goes purple or whatever, then really think in your mind that this is quite likely going to be pertussis. School-age children, generally we would hope have been vaccinated. And if they have been vaccinated, the disease is less severe. So it's really unusual for this disease to, cause morbidity in older children, particularly for people that have been vaccinated for sure. But they're more likely to display those really typical symptoms of pertussis. They're having those coughing spasms and having that inspiratory whooping sound. Quite often they'll have this, post-coughing fit vomiting that they talk about. Adolescents and adults are even more difficult to diagnose because they've just got this cough that just won't go away. So first of all, they'll present probably to a GP with a bad cough, and they'll probably be sent home with some type of a cough medicine, etc. So it can quite often take a few visits to a GP before whooping cough is diagnosed in an adolescent or an adult. So just be mindful that people that are presenting with a cough that's reasonably persistent, particularly for people that are unable to complete a sentence without having a coughing fit, it's more likely going to be the fact that they've got a pertussis infection. So there's the 3 stages. We've got that early cold symptoms stage. We've then got that horrible coughing stage, particularly little babies and very young children during stage 2 with those coughing fits. They'll often turn blue, they'll choke on that mucus. Unfortunately, if anyone's ever looked after a child with whooping cough, you've just got to give them supportive therapy, suck mucus out, give them some oxygen, and just cross your fingers and legs and everything else to hope they take that next breath. But that coughing spasm in little tiny babies can often be triggered by the fact that they're crying or that they have been feeding. If they get a little bit excited, so if you've got a child with pertussis and you're trying to play with them and make them laugh and giggle, that could be enough to set them off into a coughing fit. But also tobacco smoke. So smoking around young babies is not a good thing to be doing. Smoking full stop is not a good thing to be doing, but never alone around a little baby that may well have whooping cough. This is a really exhausting disease. These coughing fits are prolonged. They use every muscle in the child's body. They can grow tired very, very, very quickly. Quite often called the 100-day cough because it just literally lasts for 100 days. And this recovery stage can be really, really slow. And we often hear that people, even though the cough has become milder and less frequent, they just feel flat for a number of months after recovering from that severe whooping cough infection. So clearly there's some very, very serious complications that caused from pertussis. But in addition to these types of complications, there's just the things like people going off their food. So older people really can't be bothered cooking anything, so they end up being little tea and toast people, And so their nutritional status certainly suffers. They suffer dehydration, and that's really dangerous in older people as well as little tiny babies. Dehydration will lead to low blood pressures and therefore increased risk of falling. People can't sleep properly, so that affects their mental health and their ability to socialise and interact with other people, even when they're not coughing as much. Certainly people can get blood noses, they can pop a hernia, they can end up with ear infections, so otitis media, and certainly stress incontinence is something that is also noted. Definitely those more severe complications really, refractory pulmonary hypertension, pneumothorax, rectal prolapses, and subdural hematomas. So something that you really don't want to get. Kidney failure can occur because of that real strong response to the inflammatory process that's caused by the pertussis toxins. So we've got a poll, Susie.
Yes, we have. One moment and I'll get that all up for you. I'm going to launch the poll, and just question number 1 at the moment. We've got 3 questions there, but question number 1.
So question number 1 is, what is the most common cause of death in people with pertussis? A, or the first, second, third, fourth. So the acute myocardial infarct, or is it pertussis pneumonia that's complicated? Is it a diabetic coma, or is it the kidney failure?
Now, we've got 76 people online at the moment.
Beautiful.
No one's voted as yet.
Okay.
Oh, we've got to vote. Give them some thinking time, I think, Angela.
Sure. And are they familiar with?
No, we've only got one coming for, one has voted so far. I'm wondering, we've got some participants who are raising hands. I'm wondering if people are having trouble actually getting to the poll. I'm going to end it and then restart it, I think, just to see.
Okay, sure.
Let's have a look again. Relaunch. We might just relaunch that. If you voted already, you can re-vote now. Interesting. We've got some people saying they can't vote.
Okay.
They're attempting to submit, but we've got others who can. So in the system, it's got that people should be able to vote. I'm wondering if at their end, people might like to check their settings just to make sure that they're able to vote. Got 4 coming through, so we've got a few that are able to now.
So
it looks like people have to answer the 3 questions to submit. I apologise, Angela. I should have.
Oh, okay. Okay.
Oh, my apologies.
That's okay. Well, shall we do the poll then, Susie, right at the end of the webinar?
All right.
And then people can answer all 3 questions at the same time.
Let's test people's memory. That's a good idea. So they've had a quick
sure.
look at it, they can have a listen and then see if they can get it 100% correct.
For sure, for sure. Okay.
Okay.
All right, so what we'll do then is we'll just continue on. So you might need to take some notes along the way, but otherwise I'm sure you'll have very good memories and you'll be able to remember most of this information.
Let's hope so.
Okay. Okay. Oh, now I've got a frozen screen, Susie, from that. There we go. Now we're ready.
All good to go.
Okay. So if we are looking at the burden of pertussis disease, we definitely do know that the highest rates of disease are in children under 6 months, or have certainly been in children under 6 months of age. Then the next notification rate increases around about those 9-year-old children through to the adolescents. We do know that this is really quite a cyclic disease. There's really clear seasonal patterns to this particular disease, with the highest number of notifications usually coming around in the late winter and in the summer months. So really between August and February. So we're really coming up into our pertussis disease season, if you like. But we do see that, you know, across the years that we have these peaks and troughs. So we definitely sort of see the highs and the lows in notifications coming through. There's probably some, you know, understanding of that, although we're not 100% sure. But we definitely know, you know, if we're looking back at the notifications, you know, we look at the big jump in 2009. Now, if you remember back in 2009, we had that lovely little, you know, little mini pandemic flu of H1N1. So it was that little swine flu outbreak that we had that caused a bit of problem around the world. And during 2009, we were asking providers to do a lot more swabs on individuals to determine whether or not these people had H1N1 flu. So obviously some of those notifications, it was not flu that the patient had, it was actually coming back as positive for Bordetella pertussis. So providers were getting in the habit then of swabbing more people that were presenting with influenza-like illnesses. And so we've seen this rise in notification rates. Does that really mean that there's been a rise across the disease profile? Has there always been high amounts of disease in the community that we've never known about because we've never been swabbing people? It's a bit of an unknown, to be honest. But what we do know is that we have waning vaccine antibodies. Our immune system, for whatever the reason, does not remember pertussis antibodies for very long. And it doesn't matter whether you have had natural pertussis disease or whether you have got vaccine-acquired antibodies, the memory does not stay for very long. So there's been some studies in regards to how soon does this vaccine immunity wane, and it really does depend on the studies, but I've picked out a couple. So there was one that was done that looked at the diphtheria, tetanus and whooping cough booster vaccine that we give. And it really said that it provided really quite moderate protection against whooping cough in the first year after vaccination, but the effectiveness wanes to less than 9% after about 4 years. And that was done amongst teenagers who had received the acellular pertussis vaccine. There was, you know, certainly other researchers that found that young children that were fully vaccinated, according to the schedule, the risk of pertussis increased the more that time passed since their last dose of pertussis-containing vaccine. So we do understand that this waning immunity is a significant driver of outbreaks of pertussis disease. So it's something that is being looked at around the world, is what to do about pertussis in regards to should we be offering booster doses of pertussis vaccine more frequently in order to keep people protected from this particular disease. But there needs to be some really good evidence that if we are vaccinating people more often, that those vaccines are actually going to be inducing immune responses, which you certainly they should, and we would expect them to. But of course, everything that we do is research-based, clinical evidence. So we've got to go through the motions of that. So if we're looking at the burden of disease last year, looking at the National Notifiable Diseases Surveillance System, as you can see, there are about 12,500 cases that were notified. So obviously, these types of diseases, such as pertussis and flu, are often really underreported because not everybody will go to a doctor and not everybody will have a swab to determine and get that laboratory confirmation of the disease. So we know that this disease is a problem in children under 15 years of age, but clearly it's a significant problem in people over 15 years of age as well. So we've got people who are travelling a lot more, we've got people that are having young babies, they're around a lot of friends with babies, we've got increased social activities amongst all children and adolescents and adults. We've got people who are attending universities, so we've got crowded environments, and we've got people in workplaces. So this disease can certainly be transmitted quite easily in all of those environments. So if we look at the geographical spread of this particular disease last year, Northern Territory does quite nicely. So if you want to avoid pertussis, it might pay to all move to the Northern Territory by the looks of this particular map. But otherwise, obviously New South Wales, highly populated state, so clearly are going to be the leaders in notification rates. If we look at where we're up to so far this year, the National Notifiable Diseases Surveillance System data as of the 4th of September, year to date, we're looking at the ACT, already have 185 notifications. New South Wales has 4,088 notifications. Northern Territory 29, Queensland 1,076, South Australia 183 cases, Tasmania 380, Victoria 1,211, and WA is 381 cases so far. So far around Australia, there's been 7,533 cases that have been notified to the disease surveillance system. So pertussis can affect people at any age, but we just do understand that very little babies and young children are particularly at risk of complications to this disease. And we talked around the fact that there's sleep disturbance, there's time off work for somebody who's got pertussis. So there's quite an impact on people's lives for the workplace, for their health, for their social aspects, financial aspects as well, if people are having to take time off work.
Angela, just if I can interrupt for a moment.
Yes.
A really interesting question here from Meryl. Do we know the vaccination status of those 12,500 reported cases?
Generally, when diseases are notified, there is a question on the notification form to whether or not the person was vaccinated. Mm-hmm. So I certainly don't have access to that data, but I do understand that that data is collected.
Okay. Tell you what, I can find out where we can access that information for Meryl. And
that would be great.
Pop that on the information that we pop on our website. Thanks, Meryl.
So I would probably suggest that there would be a number of those people, Meryl, that are vaccinated, because of course we need to understand that vaccines, generally most vaccines in fact, are not 100% effective in 100% of people that we give them to. Every vaccine has a different degree of efficacy. So we would expect vaccines to reduce the likelihood that somebody will contract disease, but most importantly, reduce their risk of developing complications. So that really is more the purpose often to get vaccinated, is just to reduce the likelihood you'll get the disease and reduce the likelihood you'll end up with complications. So yeah, we would expect that some of those people probably have been vaccinated, and we know particularly with this that it doesn't have the greatest of efficacy, and we do know that that vaccine immunity does wane rather quickly. So we talked about those little tiny babies, definitely more at risk of those serious complications, and obviously including death. When we look at the deaths of infants from pertussis, generally they are in babies that have not yet received their first dose of pertussis-containing vaccine. So we will talk about the purpose of vaccinating pregnant women, pregnancy, with a pertussis-containing vaccine. But that change to the program was made really so we could give these maternal antibodies to those little tiny babies before they were old enough to receive their own first dose of vaccine. So we would often say, before we started vaccinating pregnant women in that program, we would often look at the first 3 doses of pertussis-containing vaccine for infants, and we would say that the first dose of vaccine an infant received was good enough to stop them from dying of the disease if they were to contract it. The second dose of vaccine was good enough to keep them out of hospital if they contracted the disease. And the third dose of vaccine was going to reduce the likelihood that they contracted the disease in the first place. So this was where our concern was if parents deferred or delayed their children's immunisation program, because that window of opportunity for this child to contract this disease was left open for as long as was unvaccinated with that first dose. So really important to get antibodies into these little babies as quickly as we possibly can, but our vaccines are only licensed to be given from 6 weeks of age. So we will talk about the Pregnant Women program shortly, but the other point that I was making is about vaccinating on time. So there is a program in place, and we do start containing vaccines for infants as early as 6 weeks, which is when the vaccines are licensed. So it is really important that these babies are protected very, very early in life. Those maternal antibodies that the baby is born with will wane around about the 4-month mark. So important that this little baby's been given the opportunity to get vaccinated and to build its own antibodies before that maternal immunity wanes away. So we've got a very robust vaccination program in Australia. We do, from time to time, wonder why we haven't got more vaccines on our schedule, but we certainly are very, very thankful for the vaccines that we do have on our schedule and the support that we do have from government around the immunisation program. So pertussis-containing vaccines are funded for children at 2 months, 4 months, 6 months, 18 months and 4 years of age. But of course, we can give that first dose as early as 6 weeks of age. We don't need to wait. So the earlier we get that protection in, the better. Because of that waning immunity, There is a school immunisation program that offers adolescents a booster dose, and it depends on what state and territory you live in to when that booster dose is offered in the school program. Certainly under the No Jab, No Pay legislation, there are free catch-up vaccines available for people up to their 20th birthday. So any child that has missed out on their vaccines, they are still able to access vaccines up until their 20th birthday. So clearly, this is our immunisation program where we are given DTP, so the capitals. So the difference between DTP and the lowercase d, capital T, lowercase p, is that with the adolescent dose that we are giving in the school program, there are less diphtheria and less pertussis antigens than what childhood vaccine, but it does have the same amount of tetanus antigens. So any adult wishes to reduce their likelihood of contracting pertussis and becoming very ill with it and risking those complications really can go ahead and have a pertussis-containing vaccine. At the moment, the interval is listed at 10 years. So if it's been more than 10 years since someone had a pertussis booster, then it would be recommended that they see their health provider and have another dose. Very aware that they probably have lost their antibodies before, and this is certainly under discussion around the world, whether or not we need to reduce that interval. Clearly, we have reduced that interval for people who have high-risk travel. Some hospitals have reduced that interval for their healthcare workers, particularly those in maternity units or natal units, and they've reduced that down to 5 years. But we also know that this vaccine is quite more frequently because we are giving it to our pregnant women pregnancy, regardless of the interval between those pregnancies. And yes, because of the tetanus component, it may well give somebody a bit of a red sore arm because of the, the antigens of the tetanus component, but we'd rather give them a little red sore arm for a few days than to risk them getting pertussis disease. So with our pregnant women, recently the criteria was changed. So the optimal time used to be 28 to 32 weeks gestation, and that was recently reviewed and brought back to 20 weeks. And this was really to enable women to have that vaccine earlier in their pregnancy, because if they happen to go into preterm labour at 23 weeks, we've got a viable fetus, and certainly there would be some antibody protection across to that little baby for pertussis. So if a pregnant woman was to be immunised with a pertussis-containing vaccine prior to 20 weeks gestation, you do not need to repeat the vaccine dose once they have reached 20 weeks. There is really good evidence to suggest that there is antibody transfer of pertussis antibodies as early as 13 weeks gestation. And there are some countries that do this pregnant program earlier than 20 weeks. Obviously, you can give this vaccine right up until when they deliver. However, we do know that after we've given a vaccine, it generally takes around about 2 weeks for those antibodies to be developed into IgG antibodies, which means that they are small enough to cross through the placenta to afford protective to the little baby. So if you were going to immunise a lady today and she went into labour tomorrow, the infant really wouldn't benefit from that particular vaccine for the mum that we've just given her. So ideally, we would definitely be recommending this vaccine in pregnant women at least 2 weeks prior to delivery. So as soon as they're turning up at 20 weeks, generally around the time that they're having a morphology scan, definitely that's the time that we should be using that opportunity to talk to them about this pertussis vaccine.
And Angela, the vaccine that's used in pregnancy, just a question about clarification, is that the booster?
They use either Boostrix or Adacel.
Okay.
So yep. The DTP vaccine, either of them doesn't matter. They are both very effective vaccines. Yep. It depends on what you've got in your fridge.
And also, just to clarify, if a pregnant lady got pertussis vaccine before turning 20 weeks, no need to repeat the dose?
No need to repeat the dose. So there's really good evidence to say that there's antibody transfer as early as 13 weeks.
Okay, thank you.
Yeah. Okay.
Now, I've just got a comment. I wonder if people can pop in a chat. I'm having some sound scratching at this end, and I've had a couple of people say that we're having some sound issues. I've done some troubleshooting at this end. Can I just get people just to comment in chat if they are having difficulty hearing Angela? So we've got a few people saying that you're breaking up a bit.
Oh, really? Okay.
Do we have anyone on another line? Because I am hearing some breathing at this end.
So maybe people need to mute.
Yeah. I've turned off the comments from the other. We don't have anyone else online? No.
No.
I'll keep working at this end.
Okay.
Continuing. Thank you.
All right. Okay, we'll do that poll later. So pregnant women are definitely a risk group. We definitely do not want pregnant women getting pertussis disease in their pregnancy. Clearly, they've got a growing fetus inside them and those ribs are stretched to the maximum as that little baby sits up underneath the rib cage. So for a mother to be having these coughing spasms is just not ideal for her at all. We do know that there are complications such as preterm labour, rupturing of membranes because of the pressure on the tummy when you're coughing. Obviously, stress incontinence for pregnant women is a problem anyway, never alone if they're having a coughing fit. But if pregnant women don't receive a vaccine in their pregnancy, we would definitely recommend that they receive the vaccine as soon as possible after pregnancy, because we want to reduce the likelihood that they will contract pertussis. And with such close contact with their little baby, so often during that 24-hour day, they are quite a significant reservoir of infection for their little tiny baby. So we'd definitely be recommending that they are vaccinated before they leave hospital or very, very, very soon after, if possible.
And there's a few more questions coming through about vaccine during pregnancy.
Yeah.
Any dangers if someone is vaccinated twice during the same pregnancy?
No, look, there's one thing that our immune system is very, very good at, and that is already working out whether there's antibodies there or not. So if there's already antibodies there, the second dose of vaccine is certainly not going to be harmful. There's no evidence at all that we can over-vaccinate people with the routine vaccines that we use. So we know that the immune system sorts that out very, very quickly. If there's antibodies already there, then there's just not going to be much benefit from having that second dose. You might get a little bit of antibody rise, absolutely, a little bit of a boost, but we can't overdose people with vaccines.
Okay. We have a question from Meryl again, just regarding vaccines now recommended for pregnancy from 20 weeks, while the
Yes.
insert states it was only tested in 793 pregnancies. Do you want to talk about that a moment and just tell us if you're concerned about that or why it was recommended without testing?
Yep, okay. So what we do know with all of the phases of testing with vaccines, that they are tested in a number of different subjects. They also look at the safety profile of the vaccine in the general population as well. And we also know that people that are in the general population that have been in clinical trials have often fallen pregnant during that clinical trial and were inadvertently vaccinated while they were pregnant. Those individuals also are followed up, and there's been absolutely no evidence of a negative outcome for the mother or the baby.
Okay.
So when they look at, all of the risks and benefits, then they look at, if we don't vaccinate pregnant women, are they at more risk of pertussis disease? And is their infant at more risk of a serious outcome from pertussis disease if it was born with no antibody protection at all? So the risk clearly is higher for pregnant women that aren't vaccinated, and the risk is clearly higher for babies that don't have any antibody protection until they can get their first dose of vaccine. So, and they are the most vulnerable group. And as I said before, they are the group that is most likely to die from pertussis infection, in those early weeks of life.
So Jackie asked an interesting question. If a mother missed her vaccination on the second child, only a couple of years after the first, is it advised to vaccinate post-birth if she's breastfeeding?
We would say yes, because of the close contact of with that baby from that mum. We know that antibodies would wane, so we would be offering a booster for that particular mum as well.
Okay, and post-delivery, Chandra asked if the vaccination is free.
No, it's not. It's only funded for pregnant women.
Okay, thank you.
So by vaccinating women postpartum, so after delivery, it's really just to offer some indirect protection to the baby, of course, because they've missed the opportunity to get maternal antibodies into the baby.
Great.
So we know that people in the household also have been identified as significant sources of infant infections. So we're aware that older siblings in the household may well have waning immunity. There's adolescents. We also know that we've got peak incidence in our adolescent programs as well. But definitely parents have been found to be a significant source of infection. And so this comes back to, if the mother didn't receive the vaccine in pregnancy, definitely vaccinate her after pregnancy. But we would definitely be suggesting that the partners, so the dads or other mothers of the baby, it's also vaccinated. So anybody that's breathing on that baby, we would hope is protected to some degree from contracting pertussis disease.
Okay, great. And the partners of the pregnant women vaccine?
Yes. No, then, unless, different states and territories may offer free vaccine to partners, but on the National Immunisation Program, the vaccine is only free for pregnant women.
Okay, thank you.
Okay.
All right. That's it.
Good.
for now.
All right, so we were saying before that we definitely want this vaccine into people within 2 weeks of them having a baby. But for anybody that's travelling that wants this vaccine so they, reduce the likelihood of getting sick while they're away, it does take around about 2 weeks for those antibodies to be built. Some mums are not letting any visitors come and see the baby unless they have been vaccinated against whooping cough. So we do get a few grandmas and grandpas contacting us and saying, oh, well, I've got to go and have it apparently because they won't let me see my grandchild. And they will stay away for 2 weeks while they wait for their antibodies to rise. So it's important that people do have their boosters to protect them. We've got some other risk groups, and these are the occupational risk groups. So childcare workers in particular, so those working with those really young children should certainly be receiving pertussis containing vaccine, and once again having a booster if it's been more than 10 years since they had their last dose. The vaccines that we use here in Australia are listed. On the National Immunisation Program, though, we have Infanrix Hexa is the chosen vaccine for the little tiny babies. Then we go to Infanrix or Tripacell on the funded program for babies at 18 months of age when they get their booster. And then for the 4-year-olds on the national program, the funded vaccine is Infanrix IPV or Quadracell. We'll do the poll later. The formulation changes obviously for the adolescents and adults, just with the lesser amounts of diphtheria and pertussis antigen in the vaccines. The vaccines that are funded in the program for the school program, so our adolescent program, for refugee and other humanitarian entrant program, and for pregnant women is either Boostrix or Adacel. The Boostrix IPV, or if you can find any Adacel polio, they are generally perhaps used more so as a travel vaccine, potentially, if somebody needed a polio booster at the same time, but otherwise it's Boostrix or Adacel.
Is there an age limit for Adacel? It shows no older than 65 on internet, but can't see further advice from...
Yeah, so we always go by the guidance of the Australian Immunisation Handbook because there's quite often variations to the product information. So expert committees around the world will look at different aspects of a vaccine or a vaccine program or vaccine recommendations, etc. And they may differ slightly from the clinical world, the real world experience of using the vaccine to what is in the product information sheet, which has to be directly related to the clinical trial. So the phases of clinical trials is the data that is used on the product information sheets. But quite often there'll be some variation to those because in the real world, where we've now got millions and millions and millions of people receiving the vaccine, then quite often recommendations may change because of that. So we have a 3-dose primary series for the little children. But even for adults that are coming in that have never been vaccinated, it would be a 3-dose series of tetanus containing vaccines. But generally, we would only recommend for adults to receive the 1 dose of a pertussis containing vaccine. But we were talking before when I was answering Meryl's question a little bit earlier around, we've got to be, as vaccine providers, we really must be transparent around the effectiveness or efficacy of a vaccine. We need to let people know that this vaccine is only, whether it's 60% effective, whether it's 75%, whether it's 85% effective. In other words, we're going to give you a vaccine today that is going to protect you. It will reduce the likelihood that you're going to contract this disease, and it will reduce the likelihood that you're going to get really ill and end up in a hospital bed or on a ventilator, or potentially, unfortunately, in a coffin. But, you could still get the disease even though you have been vaccinated. And we see this with chickenpox, and we see it with flu, etc., because very, very few of our vaccines are 100% effective. We talked about the waning immunity over time. So some other study data from that, there was a study done in 2016 that suggested that vaccine effectiveness in that first year was around about 80%, went to about 84% over the next couple of years, but then sort of started dropping away at 4 to 7 years after vaccination and dropped down to around about 62%, and then dropping down around the 8 years post-vaccination to around about 41%. So we definitely know that there's good evidence to support that there is waning immunity. Definitely we know that in different age cohorts, the vaccine does perform better. So in regards to adolescents and adults, we do know that efficacy against confirmed pertussis was reasonably good within 2.5 years of vaccination. And that certainly does, those antibodies do tend to wane, absolutely. But, if we can continue to really advocate for booster doses of vaccine, it'll be interesting to see what change to recommendations get made as more and more evidence comes forward of this vaccine immunity that does wane. So there's been quite significant research done in regards to vaccinating of pregnant women. And a lot of that research has been done in a program in the United Kingdom, where they did look at vaccinating women right up to 7 days before delivery. And they still saw quite significant reduction in pertussis disease in those infants in their first 3 months of age, which is excellent. So we would definitely advocate to vaccinate pregnant women in that optimal time frame of between 20 weeks and 32 weeks. However, we can get this vaccine into pregnant women up until they deliver, but preferably within 2 weeks or absolutely 1 week before they deliver. So we talked earlier about making sure that other members of the family were vaccinated to help protect this infant. And this is sort of a cocoon, what they call a cocoon approach. Now, cocooning works reasonably well if people don't take the baby outside of the cocoon. All fine for people to have grandma, grandpa and all the siblings and the aunties and uncles all vaccinated. But if they're then going to take that child to the supermarket or to the netball courts or to the royal show, then clearly that cocoon strategy is really not going to work, because as soon as that baby is out into those environments, it's going to be put at risk of contracting this disease by somebody that they don't know. So Interestingly, you know, we always liken this particular scenario to people who buy a new little puppy and the vet says, do not take it outside of your yard until it's had all of its vaccines. And most people will abide by that. They do not take their little puppy out and about on the streets until it's received all of its vaccines. But for some reason, that doesn't seem to apply to babies. And look, we understand that parents do need to go to the supermarket and get their groceries, and they do need to drop older children off at school. So babies are a lot more mobile and are needing to get out of the house more than the puppy is. But it really is about protecting that baby from people that may well be coughing around it. So in regards to vaccine safety, we do know that there is a chance of fever, quite typically. So we used to have a whole cell pertussis vaccine. You'll see there it's a DTPW. The W means it was a whole cell vaccine. The immune system recognises a whole cell vaccine as more of a threat because it's seeing the whole cell. So what happens then is the antigen presenting cells do their job. They call for help from the T helper cells. The T helper cells will then send out the chemical cytokines. Those chemical cytokines are what then pushes our fever up. So that's the start of our immune system really going to work hard to develop antibodies. So with the DTPW, those fevers were quite high. A number of children went on to have febrile convulsions, and some of those children, unfortunately, did suffer neurological damage. Now, because of that, parents, understandably, became very frightened of this vaccine, so they stopped vaccinating. Unfortunately, the incidence of pertussis rose. Children were getting pertussis disease, and some of them were dying from pertussis. So we now use an acellular pertussis vaccine. In other words, they've just taken part of the pertussis cells in order to produce the vaccine. So this particular vaccine is not recognised as well by our immune system. However, it is all about safety first. So yes, we don't have a vaccine that perhaps is as effective as DTPW, but it is a safer vaccine. So what we see now is potentially some limb swelling. In regards to limb swelling, there is a definition of extensive limb swelling, and that means that the swelling with or without redness extends from the joint above the injection site to the joint below the injection site, or beyond a joint, above or below the injection site. Or it results in the circumference of the limb being twice the normal size. So there is specific criteria for it to be classified as an extensive limb swelling incident, which is a reportable adverse event. So if somebody gets a little bit of redness and swelling, but it doesn't involve the joint above or below, and certainly the circumference of that limb is not twice the size, then we wouldn't generally report that. It's a fairly acceptable adverse event. They resolve completely. There's no long-term sequelae at all. So this might help too, Meryl, with the fact that, you know, the studies that have been, undertaken do show that there isn't an adverse risk to the pregnancy in regards to stillbirths or fetal distress, any of those that are listed there. So as with all vaccines, there are really only two true contraindications to a vaccine. And one is that the person has had an anaphylactic reaction to a previous dose of the vaccine, or they've had an anaphylactic reaction to a component that is in the vaccine. So as a vaccine provider, we always must know, what are we giving? Why are we giving it? How are we giving it? To whom are we giving it? And when should we be giving it? There might be reason to defer vaccination, and that would definitely be if a child is febrile on the day of vaccination, which means a temperature of 38.5 degrees or higher on the day of vaccination. If somebody does have a pertussis infection, they are treated with antibiotics. If they have been coughing for longer than 3 weeks, then they don't usually worry about the antibiotics because they've already spread the disease everywhere that they're going to be spreading it anyway. But definitely your azithromycin is your drug of choice, to be quite honest. Your clarithromycin for sure. Erythromycin is active against pertussis, but it does have variable absorption and it does have frequent gastrointestinal side effects. So just be a little bit careful in regards to using erythromycin. And definitely you could not use erythromycin in infants less than 1 month of age if they have pertussis disease, just because there is an association of that particular antibiotic with pyloric stenosis in infants. There is no reason that we would give an immunoglobulin to anybody, so passive immunisation with normal human immunoglobulin does not prevent pertussis infection either. So definitely antibiotics for children. There is what they call the series of national guidelines, or SONGS, SONGS, on the Department of Health website for a range of notifiable diseases. So there is definitely one for pertussis. Please download it or save it somewhere so you know where to find it. But that will go through all of the guidelines around managing pertussis cases, because they do differ. So if you are looking at a household where the household contacts include an incompletely vaccinated baby less than 6 months, or if there is a woman in the household that's in the last month of pregnancy, you would give antibiotics to all of the household members, regardless of their vaccination status. If there's a case in a childcare centre, it would really depend on the vaccination status of the children in the room where the case has been, the vaccination status of staff, etc. It depends on whether there's more than one child that's been notified. So if there's been 2 or more children with pertussis disease in a childcare centre and they happen to be in the same age group room, then that means that there could be antibiotics offered to all children regardless of their immunisation status. So those guidelines are quite complex, so definitely hop onto the Department of Health website and understand what you need to do to manage that. So we talked about the fact that this is a very highly contagious respiratory infection. Little babies may not have those characteristic symptoms of the whooping sound. They may just stop breathing. The they are at the greatest risk. So it's important to get pregnant women vaccinated to get that maternal antibody transfer. So these little babies are born with a degree of protection against whooping cough. To date, there has not been a death of an infant from a mother that has received vaccine in her pregnancy. So that is excellent news. So there's boosters available through the childhood program and the school program, and obviously for people who are refugees or on humanitarian visas.
And Angela, sorry to interrupt, but
Yep.
Just on the booster, if it's advised every 10 years, we do have a question just about boosters in elderly, so into the 70s through to 90s. Are there any complications there?
No, we would certainly be recommending for them to have a booster of DTP as well, because certainly a disease like pertussis in an elderly person is a really awful disease. It's an exhausting disease. And as we know, as we age and we get that immunosenescence setting in, we don't respond well to disease or to vaccines. So we would definitely want them still to have some protection from a vaccine booster.
Okay, and there's no funding at this stage for that?
No, so the only funded program is for children, adolescents in the school program, pregnant women and refugees and others on humanitarian visas.
Thank you.
Okay.
Great. Would you like me to bring up the...
Yes, if you'd like to do the poll, then that would be absolutely great. And then people can
Thank you.
submit.
All right, we are live.
So question 1, what is the most common cause of death in people with pertussis? Number 2, when are maternal antibodies likely to be transported to the fetus? We definitely gave away that answer well and truly.
Okay, now people need to answer the 3 questions and then I can give you some results if you like.
Okay. And then the 3rd is when we are reconstituting. Even though we should be giving the vaccine as soon as practical after we have reconstituted it, that doesn't happen. How long can we actually store it for? Stored.
With regard to the results of the poll,
Sure.
we had 84% with the answer B, pertussis pneumonia.
Good. Yes, that is the correct answer.
For question 2, we had an interesting spread actually. We had 45% who said from 13 weeks onwards with the maximum transfer 30 weeks gestation, which is C.
Yep.
And then we had an equal spread between A and B.
Okay. So look, definitely we would be wanting, we do know that antibodies are transferred from 13 weeks and absolute maximum antibody transfer by 30 weeks. Certainly will be antibody transfer after 30 weeks. So answer is C on that one.
Thank you. And for question number 3, we had a lovely 71%
Lovely.
on C, interestingly.
Right. Okay. Well, I'll surprise you all and say that it's actually D. So the vaccine could actually be held at room temperature, but for not more than 8 hours.
Amazing. Thank you, Angela. I'm just wondering, because we have gone over time, if it's just worth now finishing up unless you've got anything further to add.
No, I'm all done. Thank you very much for everybody's time. And thanks, Susie, for your help.
So from the Immunisation Coalition, thanks, Angela, once again for a great presentation. Thanks to all who attended. We will be sending attendance certificates out within the next 2 weeks. The recording will be uploaded to the website along with our pertussis guide from Immunisation Coalition. So ending, thank you very much, and we'll see you next time at Immunisation Coalition webinars.
Thank you, everybody, for your time.
Bye.
Thank you.
Bye.